So hello everyone, and welcome to the next in the Innovation Support Unit webinar series. Today I'm really happy to have Gray Scholler here, who is the president of the BC Association of Community Health Centers. And he is going to be giving us an overview of what community health centers are in BC and how they relate to team-based care.
Well, thanks everybody for making time in your day to attend today, and hopefully this will be interesting for you. And thank you for the opportunity to speak. My name is Gray. I'm a registered nurse by background. I've spent prior to taking over as a director of health services here at Kool-Aid. I spent 10 years working as a registered nurse in the Kool-Aid Community Health Center here in Victoria, working as part of a team-based care. And I'm working alongside Morgan here in the clinic at a primary healthcare center, serving primarily people living with chronic mental health and substance use challenges, some of whom are homeless, but most of whom are living in poverty, I would say, is the overriding kind of theme there. So, sorry here, I'm just going to move this off so I can see what I'm looking at. There we go. So our goals for today, just to define what are we talking about when we talk about community health centers. What does team-based care look like in the CHC setting? A little background on CHCs in Canada and in British Columbia. As the title alludes to, community health centers are not a new thing here in Canada and have a long and great tradition here. Talk a little bit about the BC Association of Community Health Centers, of which I'm the current president, and then talk about what's going on with the Ministry of Health right now around CHC policy and the primary care networks, which is all really exciting development if you're into team-based care and access to primary health care in the community. So what is a community health center? Well, lots of things call themselves community health centers. I see the title written on various signs all over. Obviously, it's not a protected title, but for the purposes of the conversation that we're having today, and when we talk about community health centers in terms of the association and what's going on with the Ministry of Health, there are some core principles. So the BC Association of Community Health Centers definition is adopted from the Canadian Association with one important difference, which is underlined there, and I'll talk about that in a second. So basically, community health centers are a place. They can be one building or they can be a few buildings, depending on where they are, usually housed within one site to reduce barriers to care. They provide team-based interdisciplinary primary care, and that's what we're talking about today. Now, what those teams look like can be really variable depending on where the CHC is and who they're serving, and we'll talk more about that. They integrate services in primary care, health promotion, and community well-being. And the important distinction there between other things like patient medical homes or different types of clinical care is that there's a real attention to population health, programming that addresses the needs of the population. So taking care beyond kind of those individual clinical encounters and looking at the health of the population as a whole and community well-being. They're community-centered, which can mean a lot of different things, and we'll talk a bit about that. And it's an important distinction in BC is that they're community-governed. And so there are community health centers in British Columbia that are run by the Health Authority. They're not able to be part of the BC Association. And for the purposes of this conversation, we're talking about community health centers that are run by community boards that are based within community. In Ontario, where there's a lot of community health centers, they include both health authority run and community governed community health centers. But in BC, we're just talking about community governance there. They actively address the social determinants of health, and they demonstrate a commitment to health equity and social justice. And what that means is really understanding that the people that we serve have barriers to accessing care. It's not enough for them to just come in and receive a diagnosis and a prescription or a care plan, that we have to actively be looking at how are they living, what are the barriers to wellness for them, and then really working with them to address those. And that's where those the composition of the teams becomes really important. Do we have providers in place to help people find housing, Are we looking at food security? Do we have ways to help people with food security? Is there someone to help them get all of the income entitlements that they're entitled to? So not just income assistance and PWD, but looking at old age pension and other forms of income that are really important for seniors. CHCs, they have been shown to deliver positive health outcomes. There's been a lot of different studies in Canada and the United States that show that people who attend CHCs use acute care less, they have reduced costs to the healthcare system, and they have equal or better health outcomes than other forms of primary care delivery. And importantly, there was a really large study done in Ontario where they compared CHCs to actually other forms of interdisciplinary or team-based care. So similar models, but not without that attention to the social determinants of health and health equity. And they found that, in fact, CHCs were better at reducing hospital and ER utilization, even compared to other models, which was great. They're community governed, so they arise out of the needs of the community. They often involve volunteers from the community and peer-based programming, and that can look really different depending on whether they're serving seniors in the Gulf Islands or they're working with people who are actively using drugs in downtown Vancouver. They're developed from community needs. So most CHCs weren't planted there by a health authority. For almost all of them, there were people living in a community that looked around and identified a need for healthcare services, for primary healthcare services in their community. They formed associations, nonprofits, and developed their community health centers out of that need. And what's really cool about that is not only are they responsive to change, but they really reflect the nature of that community. And their people have an investment in them. They have ownership over their community health centers, which is really, really cool. I think it's important for specific populations that might face barriers to care in other settings to have a CHC. So we know that there's really strong interest in the First Nations Health Authority around developing CHCs to identify, to fill gaps in healthcare for Indigenous communities around the province. CHCs, because they respond to the community, because they share the culture and the understanding of the community, are great places to access care for people that are actively using drugs, that are newcomers to Canada, that might be transgendered, and it might feel discriminated against or barriers in other types of healthcare settings.
Great. It's Morgan here. I have a quick question.
Yeah.
You talked a couple times about population and the population focus of CHCs. In this case, I think you're hinting at more of a targeted population, and less so just a geographic population. Is that the case for CHCs, or can it be either?
Are you looking at the slide?
Well, there we go. Perfect. So just
very pointed of you. Yeah, so I think when we talk about populations, when we talk about the community, it can be imagined in different ways, and obviously community can represent all kinds of things. So some community health centers are absolutely place-based, so they're serving a particular geographic region, and we see this both in urban and in rural areas, but particularly in rural areas where often the CHC would be the only source of healthcare in that area, or the main source of healthcare in that area, and they would be kind of that typical cradle to grave healthcare. So serving families, seniors, doing palliative care, and filling in all the gaps. And I've listed some examples there. So Hornby Denman and Pender Harbor being examples of rural CHCs that are place-based, and then Reach and Mid-Main, which are CHCs in Vancouver, which tend to be geographically based. But then there are other types of CHCs that are population-based. So, and we see this particularly in urban locations where there's the population density to support different types of healthcare services. And that's where we have different groups that feel like they might be particularly comfortable accessing care in a setting where there's specialized knowledge amongst the providers, where the faces in the waiting room and amongst the providers are familiar, where their services are tailored to reduce barriers to care that they might encounter in different settings. And so those could be, again, newcomers. So I think of the Umbrella Health Co-op in New Westminster that serves newcomers to Canada. It's a member of the BC Association. Seniors So mental health, so a CHC like Kool-Aid, which there is other primary health care around us, but we're responsible for kind of a lot of the care for people living with chronic mental health in our area. And transgendered and sexual health. So something like the Catherine White Holman Center in Vancouver, which really has a particular population that they're working with. Or in some cases, they can be a combination of both. So I think of some rural services that might have specialized care within that. So they might have a seniors program or a home care program, or they might have a newcomers program as well, or they might do some Indigenous health. So they can be a mix. And this is really an interesting conversation that we're having with the Ministry of Health right now. There is an overall perception that community health centers are expensive because you're paying for multiple providers. The physicians aren't paying for the setting through their own fee for service. So it requires kind of more funding from health authorities and the Ministry of Health. And because they feel like it's a higher cost, they want it reserved for populations which are higher cost to the healthcare system. So they say, fine, we'll support a CHC, but you have to support people with the highest level of complexity. We disagree a bit. We think that CHCs are good value for any population. We also think that it's important that there be the opportunity to mix groups. So a place like Reach or Mid-Main might have a certain portion of their service or funding allocated for higher complexity, but they should also be able to serve the people that live across the street from them, that live in the neighborhood, and really still be rooted in the community. So in the conversations that we're having moving forward, we'd really like to see the opportunity for a mixed service base and mixed funding for some of our CHCs. Now others like Kool-Aid, the one where I work at, Catherine White Holman, Umbrella, that may not be their goal. They may be very happy working with a particular group, but we think there should be that option.
Great, we've got a question on the chat line.
Okay.
Rita's asking for place-based community health centers, how do you prevent them from being overrun by the most advantaged? So people looking for the best quality care as opposed to seeking more equity.
Yeah, so I and I don't have a really good answer for that right now because it's not something that's been well established. So some CHCs have portions of their service that are allocated to certain levels of complexity. So they'll do an intake with people, they'll look at the number of health conditions they're coming with, and different places use different complexity measures, and they'll come up with a formula that gives them a score, and they'll allocate a certain amount of care to that. I don't have a really good answer, and that is one of the sticking points that we know that that funders are concerned about, is that they will be kind of hubs for people. They know that there's really great interdisciplinary care there, that they'll travel from out of area to access care there, and maybe displacing people with higher needs that are in the local community that don't have that kind of safe healthcare literacy to know to access the services there. So I don't have a great answer for you right now, but we don't think that that's an insurmountable obstacle to sharing care for different populations within the same setting.
Rita follows up with, and Rita, you could always unmute and speak for yourself, but in the chat she says, the need for primary care is so acute that exactly as you said, that she's worrying that people with the most resources will figure out where to go to.
Absolutely, and it is a concern. I'm working with a local organization here around developing the community health center in their community, and that's one of the things that they're really concerned about. They're near a highway. They know that there's thousands, tens of thousands of people in the region without a provider, and that they will become hubs. So I think it's up to the community that's owning that health center to figure out how they want to determine who they're seeing, how to set those parameters for who would be accessing care there. So team-based care in the CHC setting. So one of the things that I think that's really neat about community health centers is that the people that work there and the services that are provided there are a reflection of the community needs. So of course you have your primary care, your physicians, your nurse practitioners, your registered nurses. You have that allied health, hopefully, physiotherapists, OT, midwives, the list goes on and on, nutrition, not meaning to leave anybody off the list, but not time to list them all. But then we look at, and we move into other areas. So I think of a CHC that I know up north where they use traditional healers. They have an elder that sits in the waiting area a couple days a week and just connects with people as they come in. They have health and wellness programming. So again, moving out of just that clinical context, offering things like here we offer a low barrier chronic pain group that brings in providers from the community that works with people on non-opioid based pain management strategies, which is really important for our population. And then roles to support access to care, which is really, really important. And this is where we've had a lot of conversation with the Ministry of Health. They're quite prepared and understand about having a team with a physio and a doc and a nurse and a pharmacist. What they're learning about and what we're working with them is to understand the importance of outreach workers, of cultural support workers, of navigators. You can have a great team sitting in a really nice building somewhere, but if people can't get there, then that's a barrier to care. And for a lot of populations, actually accessing care, either due to physical or psychiatric barriers, leaving their home can be really big. And then again, taking care out of the center. So if people need to go into the hospital, if they need to access specialized services, somebody to go along with them, someone to help support care within the CHC itself. So at Umbrella, for them, it's particularly important that they have people that are fluent in multiple languages, that understand the culture of the clients that they're working with and how that relates to how they manage their healthcare. And we think it's really important that, particularly in settings, CHCs, where you are doing more specialized care, that you have access to those roles. The clinical roles are really important, but all of those other pieces are also important. And then program coordinators. So it's great to have all of those people sitting under one roof, but you do need, a paid person to actually look at how they're working together. As any of you that work in busy clinical settings know, there's a real temptation to just get to work in the morning, see clients all day. You interact with your colleagues throughout the day around particular clients as they come up, and then we go home to our lives. But who's looking after how we're working together? Who's looking after, is there a better way to be delivering care? Can we be doing this in group care? Where are the gaps in our care? And I know it sounds kind of obvious to say that, but if you look at my own CHC and how we're funded, we're pretty well funded for providers, but there's not a lot of funding available to actually coordinate the care. And I think we've done a good job of that with the resources we have, but we could easily have another person here that really looks at how we deliver programs, that's coordinating care amongst the providers. And when we've talked about funding with the Ministry of Health, that's again another position where there's been a lot of conversation and dialogue. It's great to have the physicians and nurses and physios and midwives and all of that there, but we got to find ways to make sure that we're providing the best care and the most efficient care. So when someone walks in the door with lower back pain, making sure that, that they have the option to see the physiotherapist, for example, that they're not always going to see the doctor as the first point of contact. The doctor may not be the most appropriate provider, and they're certainly the most expensive. So finding ways to make sure that the right clients are seeing the right provider for the right conditions at the right time is really key to providing good care and to have good efficiencies within the team-based setting.
Great, this is Rita, and I'm going to speak for myself this time. Thank you very much. This is really interesting. I'm just wondering if your program coordinator, would that be similar to either like a community developer, somebody who is outward facing and then translating that into the workings of the clinic or the CHC, or is it more of a like a quality ongoing evaluation project person?
I mean, ideally you would have both roles within the CHC, and I think depending on the scale of your CHC, that might be divided into two functions or several functions, or for example, in our CHC, that's me. So I'm doing the quality assurance and looking at the team-based, but I'm also looking at the community and community needs and helping to try to bring that into our team and figuring out ways to address gaps. When you look at some place like CUPS or the ALEX, two really large, robust CHCs in Calgary, they have the administrative capacity to have people that are looking both internally and then a different group of people that are looking externally. So I think if you have the scale, ideally you would have different people doing that. I would say one of the things, and this is just me speaking from my own personal experience, I think those people that are doing the program coordination within the clinic, I think ideally they're people that have worked in those settings as well. I mean, I think it's really great to have people with a policy background and perspective, but I think it's really important that there are people in positions of leadership that have a clinical basis as well and can speak from the not only the provider experience, but the experience of clients and different challenges and things that they've learned from working with clients over the years as well.
Great, you've got some cheers on the chat for these ideas, and you're just answering the question that I had again. So thank you for that. Is there a particular clinical roles that you think are well suited to the program coordinator within the clinic?
No.
Yeah, no, yeah, I mean, other than nurses, because I knew you were going to say that too.
That's my answer for everything, Morgan. You know that.
Yeah, I do.
Again, I don't think it has to be a particular type of role. I think it's a person that has to have a particular interest and skill set. And again, this is my own opinion. I do think having some kind of clinical background is helpful. There might be individuals that don't come from a clinical background that can fill in that role, but I do think understanding the mechanics of how a team works, what it's like to work with clients, what are the day-to-day challenges and frustrations are important. Beyond that, I think it could come from any role within the clinic if that person has that interest. It doesn't have to be a physician, it doesn't have to be a nurse. It could be somebody else.
Thank you.
So just a little bit of background, as the title alluded to, a century of team-based care. Mount Carmel Clinic was founded in 1926 in Winnipeg. It's the first kind of recognized CHC in Canada. And we know in the United States that CHCs have been around for a long time there. And I'm not going to talk about it today, but it is interesting to point out that the model of CHCs, which would seem to be a good fit in Canada, are actually much more robust in the United States. And there's thousands of them there, and many of them federally funded to meet the needs of newcomers and migrants and things like that. So there's a very, very robust system of CHCs that are very well organized, and they have a lot of good organizations supporting them as well. So we're a little bit behind our southern neighbors in that regard. There are provincial associations for CHCs in BC, Alberta, Manitoba, Ontario, and Nova Scotia. I think if you know anything about CHCs in Canada, you probably know that Ontario has kind of the most robust network. For years, they've been ministry funded, so they've been a formally acknowledged part of the healthcare system in Ontario for some time. They have 107 community health centers there, and they do represent both community and health authority governed. And there's different iterations. There's Aboriginal access centers, different types there in Ontario as well. And that's where a lot of our learning here in BC has come from. There's definitely, I think there's important differences in the provinces, but lots to be learned from Ontario as well. And of course, we are trying to grow all the time. Since joining the BC Association last year, I field calls all the time, at least one a week, from different communities wanting to have a CHC, wanting to know how to develop them. So tremendous interest out there, which is really fantastic. In BC, it's hard to say how many CHCs there are in BC. They're highly heterogeneous. There's never been a formal system here to fund them. There's never been a policy. There's never been kind of anything that links them together. There's never been a system to really develop them as a group. So they've all kind of sprouted up in these communities based on the capacity of the community, what sources of funding they've been able to find, the needs of the community. And as a result, we see all kinds of different CHCs in BC. And I think it's both a challenge and a strength. I mean, there's a lot of diversity there, a lot to be learned from different models. And in many cases, what a lot of them are lacking is just some stable funding. And again, that capacity to kind of coordinate their services. So a lot of providers that we consider to be CHCs, the care often tends to be more co-located than coordinated because they are lacking that program coordination. They're funded in all kinds of ways. Some get health authority funding, grants and donations. Some use a combination of MSP billing and leverage that into other forms of providers. Some have AP contracts, pharmacy revenue. I haven't listed it, but there's other things like in the Gulf Islands, they'll use property levies or tax levies to generate some funds to support the community health centers as well. We think that moving forward, we think that diversity in funding possibilities is a strength. We'd like to see the need to go to all those sources decreased, so some ongoing core funding. But I think, one of the things when we talk to the Ministry of Health is say, for every dollar that you invest in a CHC, we're going to go out and find additional cents and dollars from all these other sources, and we'll leverage that funding into additional services in a way that the health authorities can't, because they can't go out and hold a fundraiser or do property levies or own a pharmacy or different things like that. Again, one of the big barriers that CHCs in BC have faced is a lack of that funding, the ability to plan and coordinate their service delivery. But all that given, they've done a remarkable job, and the communities should really be commended on what they've managed to achieve with not a lot in terms of resources. So the BC Association of Community Health Centers, we are new. We were formed in 2016, but really we were incorporated February last year. So we're really only about 15 months old. Community health centers in BC have been working together in different forms for decades. Reach Community Health Center in Vancouver is 50 years old. There are other CHCs that have been around for decades, and there's been that conversation and just kind of that organic movement. People that have worked at one CHC have worked at another. They've gotten together in different ways, but really with the support of the Canadian Association of Community Health Centers, they really kind of brought us to the table, helped us to get our documents together, helped us to get us moving, form a coherent policy. And so we formed last February, and it was just, I forget the expression, sometimes better to be lucky than good. And we were just so fortunate that we formed right when we did, right before the provincial election, which has really springboarded us into all types of possibilities. So we started off with 5 members and 5 board members, one from each of our CHCs. We sent out a letter to all of the political parties asking for some commitments to primary healthcare prior to the election. We received really positive support from all of the parties. We took that information, we went back out to the community. We were able to increase our membership quite quickly. Currently, we're at 14 members, and we have 3 kind of associate members that don't have CHCs yet, but have boards. They have land identified. They just have yet to get their providers in there, but we know that's happening soon. We made the decision to not include health authority CHCs. We thought it was really important to maintain our autonomy, to be able to advocate for particular issues that might be problematic for a health authority to comment on. So we can come out and be critical of the government. We can talk about income entitlements. We can talk about different types of racialization or gender-based discrimination or different things that might be barriers to care in a way that health authority community health centers can't. We can also protect ourselves. So Irene Clarence, who's the ED at Mid-Main, gives a great example of talking about when the Evergreen Community Health Center closed down. She had to go over from Mid-Main to talk about them closing down because no one there was authorized to speak about it because they worked for the health authority. And lastly, CHCs in BC they're all over the place. They're in the cities, they're in the country, and they serve lots of different populations. So we sent out this letter to the provinces. We asked for 4 things to the different political parties. We asked for transitional funding to get stabilized, for a partnership table to talk about how to enhance primary healthcare moving forward and to include CHCs in there. We asked for a commitment to CHC funding and for 20 new CHCs by 2020. All of the parties expressed some degree of support. The NDP fortunately said that they would do all of them. And then they got elected. And then we sent them a letter saying, see all the things you promised us? And to their credit, they've come to the table. We've received the transitional funding. We're at a partnership table right now talking about CHC policy, which I'll talk a little bit more. And it's been really transformative for CHCs in British Columbia within a really short span. So it's just been tremendous. So when we're at the table with the Ministry of Health, what are we asking for? What does CHCs and BAC want? Well, we want them to be available where there's community need. So if you're in a community and you want a CHC, there should be a clear process for how to get that. What do you need to show? What do you need to have in terms of governance? How do you express needs? How do you develop a plan? Right now, people just, they beat the bush looking for the appropriate email to find at the Ministry of Health of somebody that might be able to point them in the right direction. We think there should be a clearly articulated process for CHCs to be developed. And the Ministry of Health agrees. We believe in global funding rather than particular provider-based agreements. So X amount of healthcare for X dollars for X amount of people. What exactly that will end up looking like, we're not sure. And I'm certainly not an expert on all the different global funding models because there's a lot of different iterations. But we think it's important that CHCs be able to determine their team composition. Right now, many of us have provider-based contracts. So we're locked into a certain type of provider, a certain number of provider, and we're not able to change that as community need changes, as we look for different opportunities. Could an RN be doing the work of an NP, or an NP do the work of a physician, physio the work of an RN, et cetera. So there should be some flexibility there. Again, we talked about this. We don't view CHCs as just for specialized populations. We think that we have the ability to serve all types of groups. And really importantly, we really are advocating for an evaluation. The funding is going to come, but how is that work evaluated? And we think it's important that it reflects a commitment to the determinants of health and equity. So it's not just about user encounter rates. It's not just about physician utilization. It's not just about chronic disease management outcomes. Those are all absolutely important things, but we need other imaginative ways to understand that we're also creating wellness in the community, and we'd love to see indicators and methods of evaluation that acknowledge that really important work as well. So we are at the partnership table. We've had a series of meetings with the Ministry of Health and other groups like the First Nations Health Authority, some client advocacy groups, some nurse practitioner groups and different provider groups. So the Ministry of Health is doing its due diligence in terms of a consultation. They now have a draft policy which recognizes CHCs as part of the primary care networks, which is tremendous. This has never happened. So we will be enshrined in the healthcare system. And a really important part of that is they've expanded their definition away from just primary care to primary health care. So acknowledging that there's a unique part of CHCs that's really important. That is about that health equity. That is about that attention to the determinants of health. And within that, they've embedded the CHC traits as part of that definition, which is tremendous. We're talking about the template and the process for CHC expansion. So how does my community get one of these? Should be an easy answer, and that's what we're looking for. And then, of course, we're talking about how they're going to be funded. And I think that, of course, when the rubber hits the road, that will be one of the big sticking points. The good news is that primary care is a provincial priority. We know from announcements in the past few weeks that we're getting new urgent care centers. They're not community health centers, but I think they definitely have a role to play. There's $150 million in funding. That's over 3 years, so $50 million a year. That can be spent pretty quickly, but it's better than what we had before. And then lots and lots of new primary care providers, many of whom I assume will be embedded within CHCs moving forward. So one of the interesting, really interesting things, and people here, I put patient care networks, primary care networks. I think they used to be patient care networks. My apologies. So the PCNs, and some of you may be more familiar with them than myself, but for those of you that maybe aren't, just generally, this is how the Ministry of Health is going to divide up primary care within the province. They are geographical or population-based service areas. So 50 to 100,000 people in urban areas, 10 to 50,000 people in rural areas. The PCNs are already up and running in some areas, not so much in other areas. It's really variable right now. There's a PCN working group that's still kind of fleshing out what they're going to look like. But at the end of the day, what the Ministry of Health wants is all the primary care to be coordinated through these networks, which will have a steering committee with stakeholders and members. And again, who's on the steering committee, who the stakeholders and members are, is still up for discussion. There are some people at the table that feel like it should be the GPSC and the divisions at the steering committee and nobody else. There are others that feel like there should be more room for community to be part of those steering committees. So not just transmitting information into the PCNs, but also having the opportunity to direct care. So CHCs are excited to be part of the PCNs, but we also have some trepidation because there are a lot of unknowns. There are going to be what are called common program agreements, community program agreements. Anyway, I can't remember the exact title, but there is going to be a contract as part of the PCN. We haven't seen what that looks like there yet. The devil is in the detail, of course. So are the PCNs going to be dictating the terms of service to community providers, or community providers going to have the ability to deliver care kind of in the ways that they have? And the concern for CHCs is that we'll become the dumping ground for kind of unattached clients that nobody else wants to see. One of our many concerns. And we're happy to see those people, but we think that it should be done in a coordinated way that involves the collaboration of the CHC. And the other element of the PCNs, and they talk a lot about different client stakeholder groups, but we know that the patient medical homes, the specialized community services will all be part of the PCNs as well. So CHCs and the PCN, and we know in some areas that they're going to be really integral. And in Pender Harbor, the Pender Harbor Community Health Center is already really involved with their PCN. There's not a lot of healthcare in that area, and so the CHC becomes a really important part of the PCN. In an urban center where there's lots and lots of different types of healthcare going on, that relationship is probably going to look a little bit different. So just to wrap up here, I think some of the challenges that we see ahead are when dollars start to get handed out, are they going to go to community-based organizations, or are they going to go to the health authorities? If the money goes through the health authorities, I think there's probably a natural fit in terms of them figuring that they're probably the ones to allocate those dollars. But we're hoping that a good portion of that funding is reserved for community providers, because we think that we have something to offer that's different than the health authority CHCs. Physician compensation, of course, is always a conversation. What is that going to look like as we move? We know it's not going to be fee for service, but we don't know what it's going to be. Who are CHCs serving? Are we only reserved for kind of the 5% of highest complexity, or is there some flexibility there to serve larger populations? And really, this big issue of the PCN and the providers, is there going to be autonomy for members of the PCN to dictate their own terms of service in terms of how they deliver care, or is care going to be parsed out from the PCN and kind of dictated from above? And that's something that we are quite concerned about. On the flip side of that, and it's always nice to end on a positive, we know that there's big support in the ministry. We know that there's support for team-based care in all circles across the province. I go to all kinds of meetings, I talk to all kinds of groups, and everybody all agrees that this is where we need to go. It's just the roadmap. How do we get there, and what does it look like at the end? And hopefully we arrive at a place that meets the needs of clients and community first, but also of our funding agencies as well. And that's me. So thank you. If there's any questions, I'm happy to answer them, and I hope there was something useful in there for you today.
Well, thank you, Gray. Absolutely, lots of interesting stuff that came out for me. Even though I work in a community health center, I learned a lot more about what's happening at the provincial level. So thank you for that. I'll open it up to see if there are questions.
Hi, this is Rita again, and I have several questions. So if anybody else has them, feel free to jump in, and I'll just take them one at a time. Gray, what kind of relationship does your organization have with the Doctors of BC directly?
We don't have a direct relationship. I've made a presentation to the GPSC. We encourage all of our members to be active participants with their divisions. I know that's not necessary, that's more locally, but we're not at the table with the Doctors of BC in a formal way. We've been at the same table through the Ministry of Health, but we don't have a formal relationship.
Okay, because at the Doctors of BC, at the Representative Assembly, which is a group of 106 elected representatives of physicians across the province, well, I'm hearing that there is a tenuous acceptance that team-based care is important. I would say that generally there's a massive canyon of acceptance, really, about how that's going to be interpreted. And so I'm a little worried about if that could potentially create a barrier.
Yeah, I mean, it's absolutely the kind of the elephant in the room, and is primary care going to be, is it going to be physician directed? Is it going to be within communities? We know that there is a conversation coming, and that's, when I was talking about the rubber hitting the road and the compensation models and all of that, I think that's part of it. And I think, governance and kind of who's dictating the terms of service is also going to be a major challenge as well. CPs are only going to be a part of the PCNs. There's going to be, there are going to be the patient medical homes. There are going to be lots of other types of primary care delivery that is more centered around physicians. We're not under the illusion that CHCs are going to be, fit for everybody, but we do think that there is an important role for them. And we do think that there is a value to having the healthcare be owned by the community and not necessarily by a particular provider group within that organization.
Right. Yeah, I think there's many physicians who are not elected members of Doctors of BC who are supportive of this movement, but currently who don't have a very loud voice in some of those places. As a follow-up on that so has it been decided who's in charge of the PCNs? Is that going to be the divisions, or?
I don't think it has been decided. So we were at a meeting on June 7th, so last Thursday, where we saw a new policy version, or a new version of the policy around CHCs. And within that, it had a very different definition of the PCN than the PCN policy that we saw in September from the Ministry of Health. And we're not clear whether that was a result of an actual change in policy or whether the way it was written. I did have a meeting with someone from the Ministry of Health this week just to talk about that, because originally the policy, the steering committees were quite expansive and included community representation and client groups.
Right.
But then the last version that we saw spoke specifically only, and I wish I had it in front of me, only I think of just the divisions and the health authorities and the doctors, I believe. So it was a much more restrictive notion. And again, we don't know what the relationship is necessarily between the steering committee and the membership and the stakeholders in terms of, what is the power dynamic there either. So I think all of that is under consideration. I know that the Ministry of Health is really looking for feedback. So if there's anybody on the line that has a particular view, I think it would be great to get that into the Ministry of Health, and I'm happy to send out the name of the person that's kind of working around that, Melissa Murdoch, who's looking for that feedback. And the BC Association will be providing a written submission this week around our views of that as well.
Yeah, I think you should. I think that needs to get picked up.
Yeah, it's really fluid right now, and I'll be the first to admit, I'm new to all this. As I like to joke, a year and a half ago I was doing foot care, and here I am, at this table right now, and so I'm learning as I go along. But it seems to me that there are a lot of undecided pieces, all kind of moving in parallel to each other, and I'm not really sure how they're going to fit. Like the CHC policy isn't finished, the PCNs haven't been decided yet. So it's hard to know exactly where all these pieces are going to land. And I've talked to lots of people at the Ministry of Health, and they also don't know. exactly where things are headed as well. So there's a lot of uncertainty, a lot of opportunity, but definitely a lot of uncertainty.
And I think, Greg, going back to one of your sort of early tenets on this topic around the community health centers being community driven and community focused. I mean, what I've seen with the divisions, at least, is that they are more intentionally community responsive than previous iterations of sort of care transformation. And so I hope that that continues to extend into the local PCNs and the patient medical homes.
I think, you know, and I think the comments before about the doctors of BC is really important, because there is a tendency, you know, to preach to the choir. Like, a lot of the people that I interact with, you know, are already by nature kind of supportive of this model. And so we hear a lot of positive voices. I know that there are other voices out there that have concerns about CHCs and about community governance. I'm not personally hearing them, but I know they're out there, and I know that those views are being expressed at different tables. We're not at those tables. We don't have access to that at this point. So I'm not under any illusion, the association's not under any illusion that there is going to be a reckoning at some point once, you know, dollars start to be allocated. What we're trying to do right now is just build the best case that we can for our model, so that when those conversations come, that there's a real understanding of the value of CHCs. And, you know, right now we have a Minister of Health that was a community organizer, that has strong roots in the community, had a community health center closed down in his riding, Evergreen, that he was concerned about. So, you know, we think we have support in the minister's office. He also, you know, I also know that, you know, he has other constituents in terms of doctors of BC that he has to be responsive to as well.
Are there any other questions for Gray? I'm looking at time, and we've got about 8 minutes left.
Covered it all.
Wait, I have this is read again. I'm sorry, I'm just really super keen, Greg.
No, it's great. I love it.
So you had mentioned a review of the evidence, and so one of the things that I'm commonly hearing is what you alluded to, the expense and a misinterpretation of some research that has been done, saying that everything in Ontario is just a mess. So,
Right.
For example, the narrative in Vancouver being delivered to the physicians is Quebec messed it up, Ontario royally messed it up, Alberta kind of got it right because they gave the money to the physicians rather than,
Yeah.
And so that is, I mean, their evidence document that they produced didn't actually have any references in it. But I'm wondering, do you have a set of references that you're commonly using? Do you know, is there anybody doing a systematic review of this kind of stuff?
There is. So again, so, you know, the data that I get is from the CHC side of things. The Association of Ontario Health Centers does a lot of work and research around this. And certainly they've produced some studies. So I think, you know, the Auditor General in Ontario produced what they, you know, what some people to be considered a fairly, you know, a fairly considerable critique of CHCs in Ontario. The association there has published a response to that as well, because I think there was some disagreement around that. Certainly, I can point you in the direction of some particular studies that we like to reference. So there is definitely evaluation. We definitely, you know, we do look at research from the United States as well, and I know it's a bit of a different context, but a lot of research, or more research, has been done there as well that also kind of shows efficacy, cost efficiency, and different things as well. Again, I know it's a different setting, but I think they are still relevant. But most of the research is coming out of Ontario. I don't, you know, I wouldn't characterize Ontario as being a big mess. I mean, they have a very robust system. They have, you know, I think close to 1 million people, something like that, being served by CHCs. Is it perfect? No. I think there were some concerns about the amount of evaluation and the type of evaluation that was happening there. To me, they didn't sound like insurmountable obstacles. They sounded like things that we in BC should be learning from. Not to throw out the baby with the bathwater, but to learn some lessons about governance, about evaluation and accountability from Ontario that we can implement here. I think in some ways it gets down to almost an ideological bent in terms of how you view these services. And I think, people in general will view data in different ways depending on kind of what their leanings are.
Thank you, Gray. I think Sarah might have had a question. She unmuted there for a second and then.
I did. Well, and I was wondering if you could speak a little bit. I know it's mostly funding structures, but about the differences between the health authority CHCs and then the kind of community-driven CHCs in terms of service delivery and kind of practice setup. Are there any real differences that jump out to you from that perspective?
So I would start this by saying I'm certainly not an expert on the health authority CHCs, and I would say in general, from what I understand and from the ones that I know about, the big difference again is that scope of practice and that attention to the determinants of health. So CHCs that are doing more community-based programming, that have other types of providers, they have more involvement from the community, volunteers, peer-based programming, doing things around food security, housing, income entitlements, access to care for seniors, and things like that. So I would say kind of the scope and the breadth of service, and then that real attention to health equity, I think is another thing that kind of separates the models from each other. I would say in general, health authority run CHCs are more expensive than community ones, and they may disagree, but again, we leverage all types of different funding. We use the strengths of our community to run our services, volunteer boards that are doing a lot of the administration, where in health authorities, there's six-figure bureaucrats doing that same work. So we think that there's a lot more efficiencies in the community model. Not to say that the health authority ones don't do good work as well, and we think that there's no reason they can't exist side by side in the system. But in particular communities that have the capacity, we think that the community governed CHC is the preferable model.
Great, thanks. That was just to clarify for me. That's great.
Yeah.
Are there any other questions for Gray today? Okay, I've waited my obligatory 17 seconds. As trained by family medicine. Gray, thank you very much for spending the hour with us and sharing what's happening with the association and your experience connecting into this whole new, not new for CHCs, but new in BC, the context of the new team-based care initiatives. And it's really interesting to get this view in. We hear a lot from the new initiatives and the press releases of the NPs and the GPs, and actually was it last week that the PharmDs were added to the mix now? Yeah. So yeah, we hear a lot about that. So it's great to get this other grassroots view. And there's now an ask to send along contact info, and I'm happy to share that out through the ISU mailing list or to individuals who want that.
Absolutely, and if there are tables where people feel like we should be sitting, I'd be happy to do that. And we have board members kind of around the province, so somebody can show up in your community, even if it's not here in Victoria.
I think that's a great idea to consider, absolutely. And the last request I have of you, Gray, at least for today, is you mentioned some references. And if you want to funnel those to me, then I can share them out through our website. Okay. That'd be wonderful. Thank you. All right. And thank you everyone for attending today. I know we're getting closer to summertime. And so this is going to be the last one before summer. We're going to send out a poll for our webinars, both if we want to do a summer session and what scheduled times will work for people in the fall. So we're going to continue this series into the fall. And so we'll look for timing and also workshop topics or webinar topics then as well. So thank you all for being involved, and thank you again, Gray, for giving us this good chance for discussion.
Thank you.